Hello, this is Dr. Yu with adult necrotizing IgA vasculitis with pulmonic, gastrointestinal, and dermatological involvement. So IgA vasculitis is a leukocytoclastic process affecting the small blood vessels, primarily of the skin, joints, the gastrointestinal tract, and the kidneys. It is a disease most common in children where it is usually self-limited. However, it does also occur in adults where the course tends to be more severe. In the short term, primary concern is often difficult to control GI bleeding. And in the longer prognosis, renal involvement is usually more significant. In our case, we have an 85-year-old Caucasian male with comorbidities including a traumatic C3, C4 spinal injury with subsequent hemiparesis, neurogenic bladder, and a stage 4 sacral pressure ulcer. His initial hospitalization was for a fever of 102.7 degrees. Initial suspicion was for a recurrent UTI or osteomyelitis, as he has history of MDRO infections in the past. He was started on broad-spectrum antibiotics, including withmarum and vancomycin. 1 week after the initial hospitalization, he developed a macular erythematous rash of the upper extremities. There was no desquamation and it was non-blanching. It originated at the extensor aspects of both forearms. 2 days later, he developed symptoms of a small bowel obstruction, and an NG tube was inserted, which drained coffee ground-like materials. 3 days after that, he developed melena, and over this time, his hemoglobin had been noted to be dropping, and he had begun to require transfusion and was transferred to the ICU. It was noted once in the ICU that the rash was becoming more extensive with almost complete involvement of the arms on the extensor surfaces and also starting to include the palmar surfaces of both hands. And there was also significant swelling in the extremities as well. A skin biopsy at this time eventually came back positive for granular IgA and C3 deposition with some weaker staining for other immune molecules and was diagnostic for IgA vasculitis. The patient underwent an EGD, which did not show any active bleeding. However, there was inflammation and erosions in the gastric antrum and some ulceration in the duodenum. High-dose steroids were started at this time for the vasculitis process, and the patient clinically stabilized with his hemoglobin stabilizing and some remission of his rash. He was transferred out of the ICU as he was improving, and steroids were begun to be tapered. However, on the floors, he experienced a significant hemoglobin drop, requiring an additional transfusion, and he also had an episode of hemoptysis. He was transferred back to the ICU for closer monitoring and additional transfusion. High-dose steroids were resumed. However, the patient continued to deteriorate due to extensive GI bleeding with very significant melena, and at this time, his family opted for comfort measures, and the patient expired 26 days after admission due to asystole secondary to acute hemorrhage. So, adult IgA vasculitis can have a severe course, and primarily due to GI bleeding in the short term. The incidence is unknown. Estimates seem to vary from 1 to 3 million per person, depending on the population examined and criteria used for diagnosis. In this case, we examined the course in an elderly 85-year-old male with extensive comorbidities. He had extensive skin and GI involvement, as well as at least one episode of hemoptysis, and he unfortunately passed from his condition 26 days after admission, primarily due to acute hemorrhage. We present this case to emphasize the importance of a timely diagnosis of IgA vasculitis with prompt initiation of immune-suppressing therapies, steroids being the typical primary choice, although there is a lack of evidence-based guidelines given the rarity of this condition. And another important lesson is that steroids may be insufficient for full control, and additional immune modulating medications should be considered, such as rituximab, that more specifically address the IgA etiology of the disease. So thank you for your time.